talking about the glenohumeral joint because that's the important exam bit in terms of the labral morphology, normal and abnormal. Then I will talk about the rotator interval and the subcoracoid space. And then finally, the superior labrum and the bicipitolateral complex. So that will be the last bit. It's a comprehensive coverage of shoulder, and hopefully over the next about 90 to 120 minutes, we should be able to quickly revise whatever is important, not just for the exam, but also for you to know how the reporting of the shoulder examination is done. So to start off with, subacromial space anatomy, we are dealing with the subacromial space and the rotator cuff tendons. I will be describing some of the normal variants of the tendon appearances and the normal appearance of the morphology. I will describe the important causes of impingement, the features of rotator cuff tendinosis and tears. What are the associated secondary signs of injury to the rotator cuff? And finally, a few words about the cuff arthropathy. So that's going to be the first almost quarter of my talk about these things. So the subacromial space essentially means the space which is present beneath the acromion and the coracoacromial arch. The coracoacromial arch is a fibro-osseous structure. So there are bits of bones which make this arch, and there are some strong ligaments and fibrous structures which complete the whole arch. So if you look here, this is a coronal image of the left shoulder. So that's the medial side, that's the lateral side. You've got your deltoid under the skin on the outside. Then you've got the acromion, and you can see the deltoid is attached to the acromion. And beneath this fat space, this is the subacromial space here. Anteriorly, we can see that from the top of the coracoid process, we've got this fibrous structure which goes laterally towards the acromion. In the sagittal plane, if you see the same things, that's the anterior, that's the posterior, that's obviously superior and inferior. You've got the coracoid process at the front. You've got the coracoacromial ligament in the middle connecting the coracoid process and the acromion. Then you've got the lateral end of the acromion and a little bit of clavicle. So together, these structures, distal clavicle, the anterior 1/3 of acromion, and the coracoacromial ligament and the coracoid process, they form the superior margins of the subacromial space. Now, what is actually present in the subacromial space? We've got the subacromial subdeltoid bursa. So there's a huge big bursal space which is present above the supraspinatus, which is the rotator cuff, below the deltoid, hence the term subacromial subdeltoid, SASD bursa. And this bursa provides a lubricating space because of which, when we move our shoulder in abduction or flexion or extension, then this lubricating space outlines the lubricating movement happening between the two groups of muscles and the fibro-osseous structures. And it is this bursa which, when gets excessively thickened and gets inflamed, the patients result in shoulder joint pain on movement, the classical subacromial impingement. More about that later. But at the moment, I just wanted you to have a look at the normal structures in the coronal and in the sagittal plane. The fact that in the coronal plane, we can see the bursal space here, and in the sagittal plane, again, anterior is towards this side. It is this space here we're talking about. And within the space, we've got the rotator cuff. We've got the supraspinatus, we've got the infraspinatus, This subscapularis is mainly in the anterior space, so we'll leave that for the moment. And we've got the long head of biceps, which is present inside the shoulder joint. So what are these rotator cuff tendons that we're talking about? The most important one, of course, is the supraspinatus. This is an arthrogram. That's the front, that's the back, that's the acromion. And we can see that the contrast medium has outlined the joint space, and the intra-articular segment of the biceps tendon can be visualized quite nicely. Above this, you've got the muscle belly and the tendon of supraspinatus. So tendon is present in the middle. Infraspinatus is present posteriorly. We can see a large hood-like tendon of infraspinatus surrounded by the muscle belly. In the coronal plane, we can see that we've got supraspinatus muscle belly coming onto the tendon, and then the tendon attaches to the front bit of the greater tuberosity. So that's the front bit. If you go further posteriorly, this is again a coronal image. This one was more anterior, this one is more posterior. We can see that at the posterior 1/3 of the greater tuberosity, we've got the infraspinatus tendon attaching. Both these tendons, they join up and they form a hood. And that hood is called the rotator cuff from this side. If you look at the same structure in the axial plane, so this is the right shoulder, and we can see that you've got the medial side here, the lateral side here, anterior and posterior. This is the greater tuberosity, and the infraspinatus muscle tendon is coming up, and then it joins the greater tuberosity at the back. Supraspinatus would have been more cranially in the upper cuts. The supraspinatus and the infraspinatus tendons, they have got a rotator cuff cable running about 1.3 centimeters medial to the greater tuberosity. So here's the greater tuberosity, that's the supraspinatus, that's the infraspinatus. Teres minor comes further posteriorly, but across the tendons of the supraspinatus and the infraspinatus, about 1.3 centimeters medial to the greater tuberosity attachment, you've got this band of tendon fibers which are running anteroposteriorly. So from the sagittal imaging, you can see that this is how it looks like. And this thickened tendon, you can see it in the deep surface of the supraspinatus and the infraspinatus tendons. And I mention that because if you're not aware of it, sometimes people call that as tendinopathy or as a tear. More so on ultrasound, because if you see ultrasound, you would notice that these tendon fibers can, because they're running at a different angle from rest of the tendon, they look a bit heterogeneous. And that heterogeneity is not necessarily abnormal, and that's actually this rotator cuff cable. You would see in about 2/3 of patients who are having MR of the shoulder, if the patient has stayed still and it's decent quality pictures. We know that the tendons, when they're attached to the bone, they normally show a low signal intensity on most MR sequences. It is this low signal intensity which, when is lost, then we make the diagnosis of tendinopathy or of a tendon tear. Sometimes, however, you would get to see a spurious increase in the signal intensity in the tendon, and that is because of the magic angle. We all know about the magic angle artifact. You tend to see it in structures which are making an angle of around 45 degrees to the main bore of the magnet. And you see them in short TE sequences, the proton densities, the T1 weighted sequences. How do you tell that it's magic angle and it's not something actually pathological? You look at a T2 weighted image, and if the signal intensity is normal on a T2, we don't call it. So here is an example, coronal image, infraspinatus. As the tendon is bending, we see that it's got an increased signal intensity, and that's a spurious increased signal intensity. If you look at the T2 weighted sequence here, in the corresponding section of infraspinatus there, we see that it's actually completely normal and there is no abnormal increase in the signal intensity. Secondly, if a patient has got their shoulder in a degree of internal rotation, then the internal rotation would result in a spurious increase in signal intensity in the rotator cuff. So that's why when you're imaging these patients, we ask the radiographers scanning them to make sure that the palm is held in external rotation, and we put a little sandbag or something on their hand so that they don't put the hand in the position of ease, which is internal rotation of the hand. It has to be completely externally rotated so that the rotator cuff is fully open and we can assess it accurately. So beware of these two pitfalls or normal variants. So what is this diagnosis of subacromial impingement? One of the commonest shoulder disorders that you can see. Up to 2/3 of patients who present with shoulder pain in the outpatient setting actually have subacromial impingement. There is a primary external impingement. We'll talk about internal impingement later on. So at the moment, just concentrate on external impingement, also called as the subacromial impingement. These are the patients who have got a chronic recurrent compression of the subacromial subdeltoid bursa and the cuff tendon between the coracoacromial arch and the humeral head. The subacromial space is narrowest in 90 degrees of abduction and 45 degrees of internal rotation of the shoulder. So you can check it yourself. If you abduct your shoulder 90 degrees and then 45 degrees internal rotation, that's the movement which the patients will catch the shoulder that, oh, it hurts there. Usually it tends to affect the critical zone of the supraspinatus, which is the muscle tendon junction about 2.5 centimeters medial to the attachment of the tendon to the greater tuberosity. Once you've got impingement, then obviously the tendons of supraspinatus and infraspinatus would be getting rubbed against the thickened bursa and the thickened coracoacromial arch. And in patients who are beyond 40 years of age, their rotator cuff can begin to show signs of attrition, thinning, and ultimately a tear. Typically, it happens at the junction of supraspinatus and infraspinatus. You can have both full thickness and partial thickness tears. As a rule of thumb, remember, the patients who got shoulder symptoms and they are beyond 40 would usually have rotator cuff pathology. Patients who are less than 40 and are referred for a potential cuff disease will actually have a glenoid labral pathology. So that's a good sort of rule of thumb to remember. Beyond 40, rotator cuff, less than 40, glenoid labrum. One of the anatomical variants can actually predispose to early rotator cuff tear, and that is type 3 acromion. So if you look at the sagittal imaging, as this is a sagittal projection, that's the coracoid process, that's the acromion, we can see that the undersurface of acromion normally is concave. But in this patient, that concavity anteriorly has resulted in a little hook-like projection. You can see that more prominently here. So the undersurface of the clavicle and the acromion has got a hook-like osteophyte, and this is called the type 3 acromion, and that impinges onto the supraspinatus and can result in a tear. If you've got acromioclavicular joint osteophytes, they can also cause impingement of the rotator cuff. So when you're reporting the shoulder MR on the sagittal imaging, please look carefully if the undersurface of acromion is simply concave or it has got an anterior hook-like projection, as is shown here. And if you've got that, that's called a type 3 acromion, and that is one of the anatomical features which can predispose patients to develop early rotator cuff tear. Beware that on the lateral end of acromion, you will have some anthesophytes. normally there are structures attached here. The coracoacromial ligament is attached to the anterior aspect. Further posteriorly, you've got the deltoid muscular slips attaching onto the acromion. They just look like slight thickenings of the low signal intensity, which is not necessarily abnormal. But in some patients, that can result in a prominent osteophyte developing there, and that can contribute to coracoacromial impingement. Notice in this patient that there is excessive fluid in the subacromial subdeltoid bursa, and there is some thickening of the muscular ligamentous attachment to the acromion. If somebody has fallen on their outstretched hand or they have impacted on the greater tuberosity, they can have a fracture. That's not an uncommon injury. And once the fracture heals, the bone becomes a bit irregular and a bit more prominent, and this results in a reduced space between the acromion and the humerus, again can predispose to early rotator cuff pathology. So I'm just showing you the normal anatomical appearances and the normal anatomical structures which, when have become degenerate and overgrown, can cause this problem. Perhaps the most important of these anatomical variations is the ossicromiale. So this is the unfused apophysis of acromion. In an axial image, that's the anterior, that's the posterior, medial, and lateral. Notice that in the axial plane, you've got an accessory ossification center of the acromion, which has not fused with the rest of acromion. This can be seen in the population over a variety of incidence figures of 1 to 15%, but on MR, it is shown in about 7% of patients. So if you ask yourselves, how many times have you reported it? Not many times, which means that we underreport them. And that's actually something which has a huge importance for the shoulder surgeons, because if we do not tell them about it, and we just tell them about rotator cuff tear, they would go ahead and repair the torn tendon, but unless they fix this, the patient will never get better. This is a site of weakness in the rotator cuff structures, and the space can there increase, and it just remains unstable, the whole shoulder. So always in the axial imaging, please carefully look for a unfused ossicromiale. Remember, it takes a long time to get fused. So up to early 20s, you can see that as a normal finding. But beyond that, it should have fused. And if you see that, then you should call it. Obviously, if you have got increased space between the joint, or edema and cyst and fluids at the adjacent margins, that's abnormal. How do you make a diagnosis of subacromial subdeltoid bursitis on MR? Well, you get to see bursal edema. So in this case, this is a coronal image. That's a lateral side, that's a medial side. You've got the biceps labral complex at the top. You've got supraspinatus tendon, and look, you've got excessive thickening, irregularly thickened bursa. It's thicker here, it's thinner there. If it's more than 3 millimeters thick, it's definitely abnormal. If it extends medial to the acromioclavicular joint, as you can see here, that's definitely abnormal. If you've got additional fluid at the extreme lateral and anterior portions of it, that's abnormal. So look at how thickened this subacromial subdeltoid bursa is. This is a sagittal projection. That's the anterior, that's the posterior. That's the flat undersurface of acromion. That's the rotator cuff, and excessively thickened subacromial subdeltoid bursa. You can get a bursal thickening not just because of impingement, but because of other primary pathologies affecting the bursal spaces like trauma, infection, and inflammatory arthropathies like rheumatoid arthritis. So be mindful of that once you see bursal fluid, it doesn't always mean that it's actually bursitis, but it can be because of other reasons also. Second stage, you get to have focal thickening of the rotator cuff. So here in this case, this is a coronal image, and we can see supraspinatus and then attaching to the greater tuberosity. You can see that normally I told you that the tendon is low signal intensity, and here it is thickened and it's swollen. This increased signal intensity can be seen in the sagittal T2 weighted sequences also. That's the anterior, that's the posterior, that's the supraspinatus, and notice how thickened it's at. In the axial image, anterior, that's the posterior, you've got excessive thickening of the supraspinatus with bright signal intensity. This is not magic angle. This is a real finding because you can see it in the long T2, long TE, T2 weighted sequences also. How do we know that this is not a tear and is just tendinopathy? Because the bright signal intensity is not as bright as water. So you can see the liquid is actually very bright, whereas this one is still sort of grayish bright, and hence we don't call that as a tear, and it's just an area of tendinopathy. What about partial thickness tears? Well, you can get articular side partial thickness tears, you can get bursal side partial thickness tears, and then you can get intrasubstance degeneration, the delamination tears. Most commonly affects the supraspinatus. The young patients can have this in trauma and in patients who play overhead sports, the ball throwers. So in this example, have a look. This is a coronal sequence. That's the supraspinatus. And as it is attached to the greater tuberosity, the endosurface is irregular. So that's a partial thickness tear of the articular surface. Another patient, this is the left-sided shoulder now. Notice the subacromial subdeltoid bursal fluid, supraspinatus coming towards the greater tuberosity. Some fibers are attached, but the bursal surface is irregularly thinned and atrophic, and you've got a partial thickness bursal side tear. This is a patient who has had an MR arthrogram, so we can see that there is fluid contrast medium in the joint. That's the supraspinatus, and again, irregular articular surface tear is seen. A patient of axial imaging of the shoulder, right shoulder. This is the subscapularis attaching to the lesser tuberosity, and here we can see increased signal intensity, which has split the tendon into a superficial and a deep lamella. So that is a delamination tear, which is a type of the intrasubstance partial thickness tear. So we've seen the articular surface partial thickness tear, bursal surface partial thickness tear, and intrasubstance partial thickness tear, or a delamination tear. There is a peculiar type of tendon abnormality which actually is seen not uncommonly, and that is the partial articular side tendon avulsion, so-called pasta lesion, also called as a rim rent tear. So this is a coronal image. You've got supraspinatus attaching to the greater tuberosity, and right at the front, we've got a bright signal intensity, and the tendon fibers are just coming off the greater tuberosity. There's a lot of edema present in the greater tuberosity on the deep surface, and that is a pasta lesion. Then we've got the reverse pasta lesion, which is a partial bursal side tendon avulsion. This is seen here. We've got bursal surface tendon avulsion developing here. And then finally, you've got the concealed intrasubstance delamination tear, which you can see just extending between the tendon fibers, like we saw in that subscapularis example I showed you earlier. So these are the special kinds of partial thickness tears, which you can see at various attachment sites of the rotator cuff. Then we move on to the full thickness rotator cuff tears. Full thickness means that the hood of the rotator cuff is avulsed completely. There is nothing separating the joint space, the glenohumeral joint space, and the subacromial subdeltoid bursa. So they both freely communicate across a full thickness tear, a punched out hole in the rotator cuff. It's usually filled with fluid. You can grade this as a small, which is less than 1 centimeter in its maximum dimension, medium, which is 1 to 3 centimeters, large, which is 3 to 5 centimeters, and a massive, which is more than 5 centimeters. Coronal image, we can see supraspinatus tendon coming, and then sort of there's nothing beyond that, so that's a full thickness tear. This is a greater example of a full thickness tear in another patient, huge big fluid-filled space connecting the subacromial subdeltoid bursa with the joint space. Another patient who's got a retracted tendon all the way up to here. Notice the atrophic changes in the deltoid. And here, the tendon retraction is almost up to the joint level with complete fatty replacement of the supraspinatus muscle belly. When you see full thickness tears, like you see here, obviously it's important to identify that, but please be careful that for this exam, they can show you multiple pathologies. And in this case, don't overlook the big elephant in the room. This is a huge, bright T2 signal intensity lesion in the proximal humerus, which is most likely to be a chondral abnormality. So it's a chondral tumor, could be chondrosarcoma. So patient has presented with a pain in the shoulder. We don't know what's the cause of the pain. Could be the rotator cuff tear, but it could easily be that also. So keep an eye out on other important pathologies once you get to see an obvious abnormality. You can try and grade the tendon tears depending on the degree of tendon retraction. So I've told you that you can grade the tears by noticing the maximum size of the defect, 1 to 3, and beyond 3 centimeters, grade 1, 2, 3. But if you don't like to measure things, then you can just eyeball it and decide that if the tendon is closer to the greater tuberosity, that is a stage 1. If the retracted tendon is below the acromioclavicular joint, it is a stage 2. And if the retracted tendon is above the glenohumeral joint, it is a stage 3. Obviously, bigger the stage, worse the prognosis. So close to the greater tuberosity, below the AC joint, and above the glenohumeral joint, 1, 2, and 3. Also important to see what is the shape of the tear. So if you've got a delamination tear with a horizontal split between the supraspinatus and the infraspinatus, then the surgical technique would be different. So we need to tell them about it. We need to clearly explain the dimensions of the tear in the 2 planes, front to back and medial to lateral. The medial to lateral extent of the tear is calculated on the coronal imaging, and the front to back tear is calculated on the sagittal imaging. So make sure that we fully explain to them it's a bursal surface partial thickness tear versus articular surface partial thickness tear versus a full thickness tear. And when it is full thickness tear, the maximum dimensions of the tear are 1.2 centimeters from medial to lateral and 1.1 centimeters from front to back. That's the sort of report that the surgeons like to hear, because it tells them exactly what they need to do to try and cure the problem. In terms of what should you be using to make the diagnosis, obviously you have to rely on what's available in your hospital. But for a partial thickness tear, the sensitivity and specificity of MR is about 60% sensitive, about 90% specific, so not very sensitive. MR arthrography, the sensitivity increases, specificity becomes better. And in ultrasound, in good hands, you can make a diagnosis of partial thickness tear in about 2/3 of patients with a sensitivity of 2/3, and then specificity is beyond 90%. For full thickness, obviously, MR does better, very good sensitivity and specificity, gets better with MR arthrography, and is also very good with ultrasound. So you can see that MR arthrography outperforms both MR and ultrasound, but not everybody has access to that. And in my experience, if you can get good quality MR and the patient can keep still, and you've got good dedicated radiographers, you should be able to see the important lesions. Here is a comparison of assessment of a partial thickness tear in conventional MR versus MR arthrography. So you can see that in the conventional MR, in this coronal image, we can see the articular surface getting slightly irregular here. There is an associated finding that there is a small subchondral geode present. And in the sagittal imaging, we can just about see some increased bright signal intensity there. But it's a bit of a tough call. Once you do an MR arthrogram, so you've got contrast medium within the joint now, and we can see much more confidently the degree of thinning of the supraspinatus tendon, and the same thing in the sagittal projection. That's the front, that's the back, and we can see irregular thinning of the undersurface of the supraspinatus. So clearly, MR arthrogram is more useful. You also need to tell the surgeons about the quality of the muscles of rotator cuff. These are sagittal images. So once you see a rotator cuff tear, then subscapularis to the front, supraspinatus in the Y of the scapula, and infraspinatus, muscle bellies are assessed. Some people say that what you do is that you draw a line from the front of the scapular blade to the back, and bits of supraspinatus should be protruding above this line. So that's the tangent sign. But some people say that you just tend to see how much of the supraspinatus fossa is covered by muscle and how much is covered by fat. So if it's normal muscle with very little fat, then that's grade 1 muscle. If it's 50-50 fat and muscle, that's grade 2. And if it's very significant fatty presence with very little muscle belly, that's just grade 3. So this is obviously a grade 3. Notice the fatty atrophy of supraspinatus and of the infraspinatus present in this patient. And compare them with a normal. That's how normal should look like, and that's very, very atrophic. So very important to tell the surgeons about that, because if the rotator cuff muscles are all fatty, then obviously they're not going to be able to do a very good job at repairing. What are the associated features of rotator cuff tear? We can get isolated atrophy of teres minor. This is a coronal image. That's the lateral side. This has been imaged right at the back. And notice infraspinatus, that's a supraspinatus there, infraspinatus muscle belly, and below that is the teres minor, marked atrophy of teres minor. Sagittal imaging, that's the front, subscapularis, that's supraspinatus, that's infraspinatus. And notice that teres minor is completely and utterly atrophic. You can get to see little cysts at the sites of the attachment of the tendinopathic tendons and the partial and full thickness tears. And if you see those, they are like a telltale sign that something's not right. But a word of caution, at the posterior head and neck junction of the humerus, you can get these little cysts as a normal variant, so don't call them. But if you see them at the front and there are other associated findings, then you can call it. Once those patients have got rotator cuff tear and the problem has been present for some time, then you can begin to see arthropathy of the glenohumeral joint. The humeral head tends to slip more cranially. Space between the acromion and the humerus is gone, and the glenohumeral joint space gets irregularly narrowed. So that's the rotator cuff related glenohumeral joint arthropathy. These can be seen in patients who have got massive full thickness tears of rotator cuff. Notice that there is absolutely no space present between the acromion and the humerus. Complete space is gone. Humeral head is actually articulating with the acetabulum, and that's what happens. This problem can be classified by this system, which is the Hamada classification. I would not expect you to know about it. Just understand the concept, right? So this is what normal is. Notice the acromion and the glenohumeral joint. Once you begin to get reduced joint space, that's stage 2. And then here, it's completely articulating the 2 bones. So that's stage 3. Stage 4 is that you get like a stage 2, but you've got early irregularly reduced glenohumeral joint space. Here, the joint space was normal. Here, it's abnormal. In 4B, you get abnormally reduced glenohumeral joint space and the abnormal articulation between acromion and the humerus. And then in stage 5, we get osteonecrosis of the humeral head. It's a very, very advanced condition. So that's how you tend to look at. So why am I telling you about this? Because rotator cuff pathology is shown in the exam. So I want you to go beyond what the average candidate would do in terms of mapping the extent of the rotator cuff. I want you to also assess about the grade of the tear, about the quality of the muscles, how much of fat is there, and about the fact if the glenohumeral joint is affected or not. If you can produce that sort of a report, your shoulder surgeons would love you. And you would very quickly be popular in the department that your reports are really helpful. So try and use that system. We'll skip that. This is a bit of an academic discussion that this classification, is it really real or not? We can leave that. Just try and remember what I've told you a bit earlier. So in a nutshell, what do you want to report? Anatomical structures, you want to see what the acromial type is. Is it a type 3 acromion or not? You want to see if there are subacromial spurs present or not. Very important, you want to make a note of the presence or absence of an os acromiale, and you want to see how osteophytic the acromioclavicular joint is. In terms of effects of all these pathologies, you want to see subacromial subdeltoid bursitis. How bad is that? You want to see the status of the rotator cuff, if there is a tear or not, if the tendon is retracted or not. You want to see the grade of the muscles. And finally, you want to see the status of the long biceps and of the glenohumeral joint. So subacromial impingement is a very common pathology, and by using MR, and in selected cases, if you have the luxury of MR arthrogram, use that. So that concludes my first, I think almost 1/3 of my talk. I'm going to carry on because we haven't reached the halfway mark yet. This is the next important bit of my talk, which is the assessment of the glenohumeral joint. Glenohumeral joint is the joint which offers the greatest range of movement in any major joint. It is reasonably stable, provided its anatomical structures are intact and it has got a good muscular support. If those features are there, then patients can demonstrate remarkable degree of movement all the way around and their shoulder still stays in place. Problems obviously happen once the static and dynamic stabilizers have gone wrong, and that's what we're going to be assessing. What are the static supporting structures for the glenohumeral joint? These are the 3 glenohumeral ligaments, superior, middle, and inferior. We've got the glenoid labrum, and we've got the glenoid rim and the cavity. Remember, the glenoid labrum and the rim are actually quite small. It's like the analogy used is the golf tee and the golf ball. The humeral head is like a golf ball, and the golf tee is the glenoid. It's a markedly oversized humeral head as compared to a relatively small cavity in which it's articulating. The dynamic stabilizers are the rotator cuff tendons, the shoulder girdle muscles, deltoid, pec major, and latissimus dorsi, and the biceps, which creates a good stabilizing effect on keeping the humeral head in its correct space. So these are the structures, the humeral head and the glenoid and the labrum, and then the muscles around it, which keep a balance of forces, which keeps the humeral head nicely and firmly attached to the glenoid labrum. What's the labrum? Labrum is, again, one of our favorite structures. It's fibrocartilage. I briefly mentioned it yesterday in my talk on the knee when we were studying menisci. So labrum is the same structure. It's fibrocartilage, and it is low signal intensity on most MR sequences. So here we can see in the coronal image, we've got the fibrocartilage here, and we've got the fibrocartilage there. And in the axial imaging, we can see the fibrocartilage here and the fibrocartilage there. This, obviously, if you do an ultrasound, if you remember, I told you yesterday that the fibrocartilage would be echogenic, which is the opposite appearance to MR. The shoulder joint capsule posteriorly is attached right at the junction of the labrum and the bone, and anteriorly it's attached on the scapular neck, a bit medial to the glenoid labrum and bone junction. So on the front there is a little bit of a space. At the back it just attaches directly onto the labrum and bone junction. The glenohumeral ligaments, these are intra-articular thickenings of the glenohumeral capsule, and you would see them nicely in a well-distended joint of MR arthrogram. So you've got the superior and the middle glenohumeral ligaments. So this is an axial image. Right at the top, you've got the biceps tendon, and right in front of the biceps, you've got the middle glenohumeral ligament. The superior glenohumeral ligament sort of intermingles with the biceps. The superior glenohumeral attaches onto the margin of the biceps pulley, bicipital groove, just around there. So in this coronal image, it's just around there where the superior glenohumeral ligament is attached. The middle glenohumeral ligament, which is more anterior, going further down, has a more variable attachment and will blend with the shoulder joint capsule quite low down. The inferior glenohumeral ligament is attached arising from the anteroinferior and the posterior glenoid labrum, and it attaches onto the humeral metaphysis. This is a structure which gets really taught when you image somebody in the position of abduction external rotation. So once the patient has been imaged in this fashion and their head, the classic position is described as a patient lies with their hand behind the head, with the shoulder abducted and externally rotated like that. And if you do that, then this structure right at the lower end is the stretched out inferior glenohumeral ligament. It's an important stabilizer of the shoulder, and we'll see examples of when it gets torn. And this is where the crux of the problem is: instability. Instability means that there is a symptomatic abnormal motion or position of the joint. It can be anterior, so the humeral head tends to fall anterior to the socket of glenoid. It can be posterior when the humeral head goes back, or it could be multidirectional, in which anywhere the humeral head can go and fall out of place. It can be because of presence of a history of trauma in terms of patients who have got an abnormal morphology of the glenoid, atraumatic, and in patients with microtraumatic problems. You can have a subluxation of the humeral head in which it is abnormally aligned in relation to the glenoid, but is still in place, versus a complete dislocation when there is completely no contact between the two. And this is the examples of which you will be asked about in the exam. The most important is anterior instability because of trauma almost always, and in patients who have a history of fall on the outstretched hand. Once you get the injuries, bones get affected in terms of Hill-Sachs defect and a bony Bankart lesion, which is a fracture of the margin, anteroinferior margin of the glenoid. The soft tissues can get affected in terms of anteroinferior capsulolabral injury. Patients who are younger than 20 years of age can have recurrent dislocation. If it's beyond 40, then only less than 20% of cases are beyond 40. So it's a problem of the young patients. And what do you get to see? This is a picture which you should all imprint in your mind, because essentially what happens is that the humeral head, which is normally positioned here, it moves anterior to the glenoid below the coracoid process. It's a subcoracoid dislocation of the humeral head. And once that happens, then the posterolateral margin of the humeral head gets bumped against here, and it gets an impaction fracture. And that is what a Hill-Sachs lesion is. Remember, in the axial imaging, in the upper two slices of the humeral head, you should be able to see a perfectly round humeral head. If you get any bumps at the posterolateral margin, that's not normal. On the fat suppressed sequences, you would see bone bruising present exactly there. Notice this defect. That's a Hill-Sachs defect. This is a sagittal image, and we can see the impacted fracture at the back with significant bone bruising. And in the axial image, if you image it there, notice that it still is at the level of the coracoid process. It should be perfectly round, and it's not. It's got an impacted fracture. So that's the classical appearance of a Hill-Sachs defect. Must remember this picture, must see more examples of it so that you don't confuse yourself. Remember, if you go further down, here, the humeral head will get a bit flattened at the back, but it doesn't really count. It's only in the top two slices or at or above the level of coracoid process where this flattening matters to be seen and reported. So this is what happens at the humeral head. What happens on the level of the glenoid? On the glenoid, if you look in the sagittal imaging, this is the front coracoid process, that's the back. And notice that the anteroinferior margin of the glenoid has got an impacted fracture and an irregular contour. In the axial imaging, this is the humeral head, this is the glenoid. Notice the fracture of the anteroinferior margin of the glenoid. So that is the classical bony Bankart. Why bony? Because it's a bone which is fractured. Why Bankart? Because it's the anteroinferior margin of the glenoid which is fractured. That's really important. That's essentially the crux of what you need to know. This is the bare minimum that you need to know. I'm going to take you beyond that so that you become not just an average, but an excellent radiologist. But this is absolute passing. If you don't pick that up, you're not passing. So remember that, please. You need to try and see how big the size of the defect is, because surgeons want to know about that. They want to know if they are able to do a standard repair, or if they have to do an augmentation procedure in which they'll get bits of bone from around to try and augment this bit of the glenoid. So try and assess how big the defect is in terms of, okay, the bone fragment is 2 centimeters in size from cranial to caudal and about 1.2 centimeters in size from front to back, so that they know how much of a glenoid needs to be repaired. I briefly told you about the fractures of greater tuberosity. They usually are seen in patients beyond 40 years of age. And you've got a significant edema of the greater tuberosity and an irregular contour later on. And this results in rotator cuff getting injured because that's the bit where the rotator cuff is attached. The fracture lines can be seen in patients who have got, in fact, quite an older injury also. So what about the soft tissue injuries? We've talked about the bony Bankart. What about the standard Bankart? Standard Bankart is just an injury of the glenoid labrum. You've got a fracture of the glenoid labrum, which is the Bankart's lesion. Then you've got an undisplaced fracture, which is the Perthes lesion. Then you've got the glenoid articular disruption lesion, the GLAD lesion. And then you've got the humeral avulsion of the inferior glenohumeral ligament, which is the Hagel lesion. So I'll show you examples of all of those. Don't worry about the complexity of the names. They're actually quite straightforward. So soft tissue Bankart is the commonest injury. Axial imaging, that's the subscapularis, so that's the front. That's the back. Notice that at the back, the glenoid labrum is sharp and triangular in shape. That's normal. Notice the front, it's gone. So that's the soft tissue Bankart. Another example here, you can see the front bit is very, very irregular and swollen in appearance, and you're expecting to see this sort of a structure there, and which is not present, and that's abnormal. In this example, you've got a fractured glenoid labrum, and then you've got a little low signal rim, which is attaching it to the bone. So that's an anterior periosteal sleeve avulsion. There's a little periosteal sleeve attached to the fractured labrum. A Perthes lesion is a partial or a complete avulsion of the anteroinferior labrum. It is non-displaced, and for that reason, you may or may not be able to see this in a standard MR examination. Ideally, you should be doing an MR arthrogram, because once the joint is distended, then you will see bits of contrast medium leaking at the site of the tear of the labrum with the underlying glenoid. So that's the Perthes lesion. We'll revisit this later on so that you all remember exactly what that means. A Perthes lesion can also be visualized if you choose to do an A-bar projection. This is an extra sequence which sometimes we do, particularly if a patient has got a suggestive history of injury. So you can see that when the patient had their imaging done in the standard projection, nicely distended joint, so good quality study. We're not entirely sure what's happening here. It seems to be intact, but once you've got them into the patient's hand behind their back posture in the A-bar projection, everything gets distended and a bit displaced, and now everybody can see the leakage of contrast medium between the labrum, which is torn, versus the glenoid. So that's abnormal, and that's a classic Perthes lesion. What's GLAD? GLAD is glenolabral articular disruption. So you've got a bit of a disruption of the articular cartilage along with the anteroinferior labral tear. So that's a GLAD lesion. A chronic GLAD lesion can have osteoarthritis of the shoulder and with a few loose bodies identified within the joint recess. So that's, again, arthrogram studies. We can see a bit of a loose body as a filling defect. A Hagel lesion is avulsion of the anterior band of the inferior glenohumeral ligament from the humerus. So coronal image, this patient has an area of bone bruising, and we can see that inferiorly, you've got a disrupted inferior glenohumeral ligaments attaching from the labrum. It should be going there, but instead it's gone into this J-shaped structure, and that's a classical appearance of a Hagel lesion. In the chronic patients, we can see that it's just going beyond that, and that structure which was keeping the joint capsule integrity is gone, and you've got a classic Hagel deformity. Sometimes you get the labrum to be detached, but it is still attached in terms of a superficial periosteal sleeve, and that's the anterior labrum periosteal sleeve avulsion lesion, ALPSA lesion. And that's what it looks like. Sometimes the displaced labrum is just scarred against the front of the anteroinferior glenoid, and that's another abnormality. Sometimes, despite our best effort, we cannot classify exactly what sort of a problem is there. And it's all right to just explain that the glenoid labrum is not normal. And this is what we're seeing. We're just seeing a huge big scar of the labrum at the anteroinferior margins. The posterior labrum is intact, but anteriorly it's grossly abnormal. And then they know that they're dealing with somebody a bit rare and a bit special. You can get injuries of the superior and middle glenohumeral ligaments. You can get slap tears. We can get subscapularis tears, and you can get rotator cuff tears, in addition to all these labral problems. So again, for the exam scenario, we have mainly covered problems of the labrum and the traumatic anterior dislocation with Hill-Sachs and Bankart lesions. Plus, remember that what we saw earlier in terms of rotator cuff, we also have to make sure that the patient hasn't got those. The both pathologies can coexist, particularly in the exam. Because of the dislocation, we know that the axillary nerve is passing right underneath the glenohumeral joint. So this is a sagittal image. That's the front, that's the back. Axillary nerve passes through the quadrilateral space just underneath here. And if it's an inferior shoulder dislocation, then that can get injured. And these are the patients who will then develop edema of the deltoid. Look here. We've got the impacted fracture, we've got rotator cuff rupture, we've got significant edema in the region of the quadrilateral space, where the axillary nerve is running along with the posterior circumflex humeral vessels. And because of the axillary nerve injury, we've got edema in the deltoid. So they love this sort of a scenario. So we can see a few findings, but then the clever students amongst you will be able to put everything together and see exactly what's happening. Hill-Sachs lesion, everybody should be able to pick that up. Rotator cuff tear, I would expect you to pick that up. But for the gold medal, I want you to see that the deltoid is markedly atrophic. And that's where the normal axillary nerve is running. And look, it's got edema also along with atrophy. So that's abnormality. There's a bit of edema of the infraspinatus at the back. So these are the sorts of things they would absolutely like you to say. I'm going to stop here because we've covered the bulk of these two cases, examples, and we'll take a 5 minutes break. Okay, so we've mainly covered the anterior instability. Now I'm going to be talking about the posterior instability, which is less common. The problem, however, is that it's an exam favorite. And the reason it's an exam favorite is that although it's less common, if you miss it, patient ends up in a lot of trouble. And there used to be a saying in our orthopedic department that if an orthopedic registrar misses a case of posterior shoulder dislocation, then our professor of orthopedics would make sure that he leaves the hospital before the weekend. It's the end of his training. So he was an old timer, I know, but that's how he used to operate. It's an uncommon condition in sportsmen, in patients who have got history of epilepsy and seizures, patients with electric shock, patients with brain abscess having spasms and seizures for whatever reason. It's a direct injury, or it happens when the patients have got a posteriorly directed force, which happens when the arm is flexed, adducted, and internally rotated. So not only fall on the outstretched hand, which we saw earlier, but in this sort of flexion, adduction, internal rotation with a posterior movement, and the shoulder just goes back. And you can imagine that if you understand that bit, whatever we studied in the anterior subluxation, you'll be able to see in the posterior subluxation in a mirror image fashion. So the impaction injury in that case was at the posterolateral margin of the humeral head. In this case, it's at the anteromedial margin of the humeral head, because humeral head is going to go back here, right? So that bit would rub against the posterior glenoid labrum. So you get a reverse Hill-Sachs lesion, and you got injuries of the posterior margin of the glenoid. So in a chronic case, notice here, the front anteromedial bit of the humeral head has got the trough-like defect, which happens when this bit went against there. There are some patients who are predisposed to get this problem, and these are the patients who have got an abnormally posteriorly directed glenoid. Normally, the glenoid is pointing this way, but if it is pointing laterally or posterolaterally, then the humeral head is sort of more prone to get dislocated posteriorly. If the glenoid is very short because of congenital reasons, then again, they would be more prone to get this sort of a dislocation. In terms of soft tissue abnormalities, again, everything happens like it happened for the standard Bankart lesion, but on the opposite side. So you've got fracture of the glenoid labrum at the back. So that's an axial image, that's the front, that's the back, and you've got a fracture there. On the front, we had Perthes lesion. When you get a similar lesion at the back, it's called a Kim lesion. So Perthes is anterior, Kim is posterior. In Pakistan, PA anterior, Perthes anterior, and K is at the back, which comes later. So you can try and remember it from that little mnemonic. It's exactly the same thing. The location is different for Perthes, which is the front, and Kim, which is at the back. At the front, we had the Alpsa lesion, anterior labrum periosteal sleeve avulsion. At the back, we get the Polpsa lesion, the posterior labrocapsular periosteal sleeve avulsion. So that's an axial image. That's the front. That's the subscapularis. That's the posterior bit. Notice that the posterior joint capsule is quite distended and full. Huge injury at the back of the capsule. Remember I told you that posteriorly the capsule attaches right at the junction of the labrum and the glenoid? Here in this case, this is an arthrogram, by the way. Notice the contrast medium leaking all the way back. And of course, the posterior labrum is gone with a little sleeve of periosteum still attached. Polpsa lesion. And then finally, you can have patients with multi-directional instability. These are the patients who can get their shoulder out anywhere, anytime. It's just because all the supporting structures are missing, weak, or gone. Happens in patients like gymnasts who do wonders on the rings and turning their body right, left, center, and everywhere. Or patients who have got congenital problems in terms of glenoid dysplasia and labroligamentous pathologies. These patients who get multi-directional instability, usually they are atraumatic. And if you do an MR arthrogram, you get to see a huge, big, very capacious, very relaxed shoulder capsule, which is just not able to keep the bones together. Big, patulous axillary pouch. The labral structures might still be normal, but everything else around the shoulder is in a complete state of mess. So conclusions in anterior, in this section of shoulder instability, the anterior post-traumatic instability is the commonest. Remember, that's the bread and butter. That's the fail pass we're talking about. Remember to see lots of examples of Hill-Sachs lesion and Bankart lesion. Then I would expect the good students amongst you to confidently make a diagnosis of Perthes and Alpsa lesions. And finally, if you really want to go for the gold medal, make sure you understand the difference between the Kim lesion, the Perthes lesions, and the other Alpsas and Pulpsas of this world. Of course, this is the indication to get an MR arthrogram. So if a patient presents with a history of instability, you should be doing an MR arthrogram. And on a standard MR, you may not be able to get all the answers. Remember, I told you that case in which even on an arthrogram, we were not able to see that Perthes defect. And only on able projection, we were able to see it. Okay, I'm going to move ahead and come to the second half of the talk, which is starting with the assessment of rotator interval and of the subcoracoid space. When you use the word rotator interval, not just the registrars, but even quite experienced consultants get a bit uneasy because it's not clear to them. There's nothing to be worried about. It's a completely simple structure, which I'm going to explain to you in terms of its landmarks. And hopefully, once you have understood that, you would have no problems in identifying the importance of rotator interval and its various landmarks. So let's start from a sagittal projection. That's the front, that's the coracoid process. That's the back, superior and inferior. So the rotator interval is a space which is present between the anterior margin of supraspinatus and the upper margin of subscapularis, right? This space is the rotator interval. What is actually present in this space? Anteriorly, we've got the coracoid process. At the top end, we've got the coracohumeral ligament. This is not the coracoacromial ligament, remember, that went to the coracoid process and the acromion, forming the coracoacromial arch. This is further medial. That was more lateral on the sagittal imaging. This is further medial, and it's the coracohumeral ligament which connects the coracoid process with the humerus. What's present within it? There is some fat, there is the anterior shoulder capsule, and you've got the biceps tendon. It is a biceps tendon which pierces the shoulder capsule in this area to go and attach to the supraglenoid tubercle of the glenoid, which is present here. Just in front of it, you've got the shoulder capsule, and because it's present in the region of the rotator interval, it's called the rotator interval capsule. The margins remain the same. Upper margin of subscapularis, anterior margin of supraspinatus, shoulder capsule, biceps tendon, coracohumeral ligament, and lots of fat. That's it, ladies and gentlemen, full stop, end of story. In the coronal imaging, you've got the coracoid process, you've got the coracohumeral ligament, you've got the fat, you've got the upper margin of the subscapularis, and somewhere here would be the anterior margin of supraspinatus. That's the rotator interval. In the axial imaging, this is now further down. The biceps tendon has already exited the front of the shoulder capsule and is present within the bicipital groove. Along with the coracohumeral ligament, you've got the superior glenohumeral ligament also present in this area, which is going to be attaching to the margins of the bicipital groove. Okay. This is a schematic drawing which just emphasizes all the anatomical structures that we've discussed. This has been taken from radiographics. So coronal imaging, you've got subscapularis, which is attaching to the lesser tuberosity. So remember, the rotator interval is upper margin of subscap. Then you've got this is the coracoacromial ligament. So your supraspinatus is going to be here, front end of the supraspinatus. So this is the rotator interval. And then you've got the coracohumeral ligament, which is from the coracoid process, attaches at the medial and lateral lips of the bicipital groove. And just deep to it would be the superior glenohumeral ligament, which attaches to the medial bit of the bicipital groove. The biceps tendon, the long head of biceps tendon, it goes there, it swings around, and then the superior glenohumeral ligament is separating the biceps tendon from the subscapularis. And then it goes to attach to the supraglenoid tubercle. So that's a simplified assessment of the structure of the rotator interval. If you look at a good quality MR arthrogram, you will be able to see these structures quite nicely. So here is your biceps tendon. See, it's swinging around over the bicipital groove here and attaching to the supraglenoid tubercle there. The superior glenohumeral ligament would be here, and then it will come around there and just attach on the medial lip of the bicipital groove. You can't see it that well here, but that's where it would be. I'll show you in a sagittal image, which shows it much better. Here's a sagittal image taken over this side. Notice this structure. That's the superior glenohumeral ligament. And this separates this upper margin of subscapularis from the biceps tendon. See how nicely it can be seen? On an axial image, that's the biceps going out towards the bicipital groove. That's seen in the sagittal imaging. You do need a MR arthrography to make these structures stand out. Why do we need to know about it? We need to know about this because of this condition, the frozen shoulder, the adhesive capsulitis. Very, very common clinical problem. So the three clinical problems we've discussed today, they're all extremely important. First two more important because we actually make a huge difference in the management of those rotator cuff tears, its associated pathologies, and the shoulder instability. Adhesive capsulitis is also important, but mostly the clinicians are happy to make the diagnosis. So what happens is that they send the patient to us. Patient, 45 years old woman complains of pain in the shoulder for the last so many weeks or months. Question mark, rotator cuff tear. If on ultrasound we can rule out a rotator cuff tear, then, and the patient has got a limited external movement and all, they know that they're dealing with an adhesive capsulitis. So it's a diagnosis of exclusion. It's a clinical diagnosis, but imaging plays an important role by ruling other important pathologies out. However, we have been documenting quite a few findings in patients with adhesive capsulitis. And in a relatively recent study, they have come up with 6 useful MR features which can be assessed to make a diagnosis of adhesive capsulitis. So what are these findings? You can get to see a thickened coracohumeral ligament. You would see that the normal presence of fat within the rotator interval is gone. You would see enhancement of the rotator interval fascia. You will see thickening stroke enhancement of the axillary capsule. You would see hyperintense and thickened inferior glenohumeral ligament. And according to this study, you have a more than 80% sensitivity and specificity to make this diagnosis. So this is absolutely useful from the fact that from making the diagnosis on the clinical grounds, we are actually now picking up findings which can positively make a diagnosis. Rather than making it a diagnosis of exclusion, we can make it a diagnosis of inclusion. And these are the examples of these signs. So coronal imaging, you've got the biceps tendon going here. We know that medial to the coracoid process, this is the region of the rotator interval. And normally I told you that this has got fat. And fat on a fat suppressed image should not be bright at all. So the fact that this area is all lighting up means that it's excessively edematous. There's synovitis present here. That's a finding in adhesive capsulitis. Then you've got excessive thickening of the axillary recess. Normally it's less than a centimeter thick. This one's quite markedly thick. Look at this patient. Huge chronic thickening of axillary recess. That's abnormal. So that's a sign of adhesive capsulitis. And then finally, in this patient, the coracoid process, humerus, excessive thickening of coracohumeral ligament. Once you've got a thickened coracohumeral ligament beyond 4 millimeters, you know that we're dealing with something abnormal here. Sagittal imaging in this patient, that's the front, that's the back, that's the top, that's the biceps tendon, that's the rotator interval. Notice the thickened coracohumeral ligament. Normally, we just about see it. Here, it's massively thickened. Notice how the fat of the rotator interval, another sagittal image, almost similar to that, all the fat in the rotator interval is gone. Notice how thick the rotator interval capsule and the CHL are in this case. Again, a sagittal image, same, supraspinatus, subscapularis, so much of extra thickening of soft tissues. So once you get excessive thickening of coracohumeral ligament by beyond 4 millimeters, or you get rotator interval capsule to get thickened by more than 7 millimeters, that's a positive sign for adhesive capsulitis. The rotator interval capsule or the shoulder joint capsule present in the region of rotator interval can be torn in patients with anterior shoulder dislocation. And this is what you get to see on MR. Obviously, the difference from the previous patients is that here there is a history of trauma. So coronal imaging, biceps tendon, rotator interval, lots of edema. Why this is not adhesive capsulitis? Because there's a different history. History is really important. Excessive thickening of coracohumeral ligament here. MR arthrogram, notice that this is the shoulder long head of biceps and the rotator interval is torn and all the contrast medium, which should have been present within the shoulder joint, is all leaking out. It's all leaking out into the subcoracoid recess. That's the traumatic rupture of the anterior shoulder capsule. The long head of biceps tendon, once it rubs against the medial lip of the bicipital groove, that's the structure of the pulley, the biceps pulley, because biceps is acting as using that bony landmark as a pulley. And once you have excessive friction of the tendon, you can get the tendon to become abnormally thickened, tendinopathic, or even torn. So notice here, this is a patient with a coronal imaging, biceps tendon. Notice as we go in the region of the pulley, tendon becomes markedly thickened and there is an increased signal intensity present here. Excessive thickening of the tendon as it swings around the biceps pulley. You get to see that in patients with overuse injury, in throwers, javelin throwers, ball throwers, basketball players. Excessive thickening of the tendon with swelling of the tendon contour. Another example, coronal imaging again, biceps tendon, notice how thickened it becomes just because of chronic friction present around here. I saw a patient with, he was a member of the Army archery team, and he was an Olympic level athlete. And unfortunately, whenever he would pull the string, he would have symptoms there, and he had excessive thickening of his biceps tendon. We did a diagnostic injection of local anesthetic only around the biceps, and that completely cured his problem for short term, but we obviously made the diagnosis that this is what's causing him the problem. If you don't take care of it, what happens? it's an abnormally thickened tendon, so it can get swollen and it can get torn. And once you get a tear of the biceps tendon, you can see that it's all curled up in the midsection of the arm. The biceps belly is all curled up, and this is the so-called Popeye sign. In the first half of the talk, I told you about osteochromialy, that this is an extremely important finding because the surgeons, if they don't know about it, they would not be looking to fix it, and the patient will not get better. This is the second problem, which you must always actively rule out. Is the biceps tendon torn or not? And if you miss an acute biceps tendon tear, then the patient's never going to get better because his biceps will very quickly turn into fat, and then they can't do anything. If you tell them about it, the surgeons, it's a very easy operation. They just go and they pin the biceps tendon to the front bit of the humerus, and they get to retain the muscle movement and the function and the power and the bulk. So very, very important. We don't see it very commonly, but once you see it, like the posterior dislocation, it's extremely important to pick up. The accuracy of MR to pick up long-head biceps tendons is significant. We can, to a significant number of patients, get to see the tendon problems. And if you get to see at least 2 signs of biceps tear, like diameter change, contour irregularity, and an altered signal intensity, then the positive predictive value is about 76% with a very high specificity. The biceps tendon can also become unstable, in which case it will slip out of the bicipital groove. It can get subluxed either on the superficial aspect of the subscapularis, within the subscapularis, or deep to the subscapularis, depending on the state of the subscapularis itself. This happens in patients with repetitive microtrauma or an acute trauma, in patients with other features of subacromial impingement and rotator cuff disease, most commonly isolated injuries of the superior glenohumeral ligament. So treatment, as I told you, biceps tenodesis and repair of the associated rotator cuff tears. So this is what you get to see in terms of biceps instability. Notice that normally the biceps should be placed within the groove. Here, you've got a very abnormal looking subscapularis, and the biceps tendon is present deep to it, just around there. Similarly, in the coronal imaging, you can't see it that well here, but on the superficial aspect of the subscapularis, we can see and spot the tendon there. It should have been here, but it's subluxed way medially on the surface of the subscapularis. So this is extra-articular subluxation, that's intra-articular subluxation. The pulley lesions are nicely described in this schematic drawing. Remember, this is the region of the rotator interval, and I told you that the coracohumeral ligament attaches to the lateral and medial lips of the biceps groove, but the superior glenohumeral ligament actually separates the subscapularis from the biceps tendon. If you have this torn, then the biceps tendon settles down onto the surface of the subscapularis. So here is the same thing in a real patient. This is the supraspinatus. That's the subscapularis, and notice the biceps tendon is just sagging onto the subscapularis. There's nothing separating the two. The superior glenohumeral ligament has been torn. Moving on to the subcoracoid space. So the coracoid process is present anteriorly, and the subscapularis is present deep to it. Between the two, we've got the subscapularis recess, which has the subscapularis bursa. Deep to the subscapularis, we've got the middle glenohumeral ligament, also present in the joint on this side. Patients with subcoracoid impingement would present with pain on the front of the shoulder, mainly with external and internal rotation of the arm. they usually have associated rotator cuff disease, which can make the humeral head to suffer from microinstability. Clinically, these patients are the ones who have chronic overuse of their shoulder. They've got pain and tenderness on the front of the shoulder, which is worse in forward flexion, adduction, and internal rotation. Anything which puts more pressure on the front of the shoulder by these movements. In terms of MR assessment, they say that if you measure their coracoid index, then that helps because obviously everybody is different. Normally, the length of coracoid process from the line of the glenohumeral joint to the tip of the coracoid is less than 8.2 millimeters. If it's beyond that, that means there's excessive bone present on the front of the subscapularis, which can cause the muscle tendon unit to get impinged upon. So that's one thing to note. Secondly, the distance between the deep surface of the coracoid and the front of the lesser tuberosity, if it's abnormally reduced, then that's abnormal. Usually it's about 11 millimeters, but in patients in whom this is less than 5 millimeters, that's very small. And like you saw earlier, the reduced space between the acromion and the top of the humerus, similarly, reduced space between the deep surface of coracoid process and the front of the humerus is going to impinge upon the subscapularis. Subcoracoid impingement, these are the patients who have got a reduced coracohumeral distance. You've got a redundant subscapularis, excessive thickening and edema present within the tendon, and subchondral changes, all the features of subscapularis tendinopathy. You can also remember there is the subcoracoid bursa present here that can get excessively distended and thickened, and this is the bursa which does not communicate with the glenohumeral joint. It can communicate with the subacromial subdeltoid bursa and can get inflamed for the same reasons for which the SD bursa was inflamed. The subscapularis tendon can also show features of tendinopathy and partial thickness or full thickness tears. I'll briefly cover this. They basically said that in patients who have got rotator cuff tears of supraspinatus and infraspinatus are more likely to get a tear of subscapularis. So they looked at lots of patients with tears of the rotator cuff, and once they found that patients who have got normal supraspinatus, subscapularis abnormality was about 1/5. If the tear size was small, if the supraspinatus becomes a larger size tear with atrophy, subscapularis tears increase, and the trend continues with the same criteria. So, nutshell, subscapularis abnormalities would be seen more commonly in patients with chronic supraspinatus tears. In acute supraspinatus tears, only in 1/5, in chronic supraspinatus tears, in almost everybody. So that's a bottom line. Why do I stress upon this point? This is just to show you that in the shoulder joint, every structure supports each other. It's a happy family unit. If there's one member of the family which is unhappy, it affects the whole family. And because we have the inherent problem of an oversized humeral head with a very small sized glenoid, it needs a good functioning unit. If one bit of the functioning unit is not working properly, the whole unit falls apart. And the longer it stays out of action, the greater the chances of finding problems. I'm not going to spend too much time on subscapularis. Just have a look. Intralamination, delamination tear, intrasubstance degeneration, superficial surface tear, a full thickness tear, complete mess. In the older age group also, obviously, the longer they have the problem, the more subscapularis tears you would see. Here you've got an impacted fracture of the greater tuberosity, thickening of the tendon, very reduced coracohumeral space, full thickness tear of the subscapularis. So Conclusion, adhesive capsulitis used to be a diagnosis of exclusion, but now with the MR findings, which I've shown, you would be able to pick up this diagnosis as a positive sign. Anterior shoulder pain, we need to look at the structure of the long end of biceps, which is best assessed by doing an MR arthrogram. I've shown you examples of subcoracoid impingement, and finally, we went through some of the examples of injuries to the subscapularis and why is it important. Now I'm coming to the final bit of my talk, which is the superior labrum and the bicipital-labral complex, the so-called SLAP lesions. SLAP stands for superior labrum anterior to posterior tears. So I'm going to be mainly covering the SLAP injuries and the concept of internal impingement. So till now, we've done two impingements in the shoulder. We did the subacromial impingement, which is also called the external impingement. Then we covered the subcoracoid impingement, which was the coracoid index and the coracohumeral space from the front. And now, towards the end, we'll discuss the internal impingement. Before that, this is one of the, probably the trickiest areas of shoulder imaging to understand, the superior labrum. Why is it tricky? Because there are lots and lots of normal variants. And it is very easy for the relatively less experienced radiologists to overcall things. The one important thing which you should all understand, and if you take it from today's talk, I think I would have done my job, is imagine the glenoid as a clock face, okay? So the front is the 3 o'clock and the back is the 9 o'clock. All the normal variants, they happen between 12 o'clock to 3 o'clock, okay? So if you see any bits of the glenoid labrum which are missing in the 12 to 3 o'clock, don't call it. If you've got glenoid defects in 3 o'clock to 12 o'clock, call it. That's the most important bit. So the clock face, 12 is superior, 3 is anterior, 6 is inferior, and 9 is posterior. That's what I just told you. So from 12 to 3, don't call it. In the coronal plane, remember, you need to have a good, nicely distended joint capsule with an MR arthrogram. And at the front, we've got the biceps tendon attaching to the superior labrum, and it's low signal intensity on everything. So that's what we need to see. You have got quite a big variety of the various attachment patterns of the biceps to the labrum. Normally, it is firmly attached here with good bit of cartilage underneath. Sometimes you get a little bit of a recess developing underneath. This recess is pointing towards a medial side and hence is normal. So that's the type 3 attachment. A type 2 attachment is when you get a small recess just at the underneath here. And a type 1 is when there's no recess at all. Okay? So that's the normal attachment patterns of the biceps to the superior labrum. Again, from American Journal AJR, they nicely describe that's the biceps tendon, that's the labrum. You can get a little recess present here, you can get a little recess present here. So that's the sublabral recess that we should not be calling as abnormal. The sublabral recess is a little cleft of the joint space which goes underneath the labrum and the biceps complex. How do we know that this is not a tear? Because it points towards the medial side, paralleling the glenoid cartilage. That's normal, okay? And it's usually very thin and 2 millimeters and smooth margins. The sublabral foramen is a little hole which is present connecting the joint space here with the subcoracoid recess. Subscapularis bursa. Subcoracoid recess is here. This is the subscapularis bursa. So normally, subcoracoid bursa doesn't communicate with the joint space. Subscapularis bursa almost always communicates with the joint space. So I'm sorry if I said subcoracoid recess here. This is wrong. This is subscapularis bursa. And this is present at the 1 o'clock to 2 o'clock junction. So don't call that. That's normal. Another important anatomical variant is the Buford complex, which is congenital absence of the anterosuperior labrum, along with a cord-like thickening of the middle glenohumeral ligament. So that's the axial image. Notice that the labrum is missing in the upper half, and there is a thick cord-like middle glenohumeral ligament. In the sagittal image, notice how thick the middle glenohumeral ligament is. The labrum is intact here, but above the 3 o'clock, it's missing there. That's seen about 1.5% of patients. It's a normal variant. Don't call that as abnormal. You can get to see a little sulcus present between the long head of biceps origin and the superior labrum. That's uncommon. That's not abnormal. Little recess paralleling the glenoid capsule. Cartilage going medially, not a tear. Then we've got our old friend, the magic angle, tends to happen at the postero-superior labrum. You would need to see a long T2 sequence to make sure that you don't call that bit as an abnormal. This is normal. Normally, we are expecting to see the labrum to be of diffuse low signal, but if you get a spurious increased signal, it's not necessarily abnormal. That's just a magic angle artifact. So now I've shown you what the normal appearance is. I've shown you what the normal variants are. And I hope that everybody would remember that as the clock face between 1 to 3, if you see something missing, don't call it. Can be the sublabral foramen or hole. If you see a little smooth recess at the attachment of the bicipitolabral complex and the undersurface of the joint space, don't call that. But in patients who have got a history of acute trauma, fall on the outstretched hand, sudden forceful traction on the long head of biceps, or in patients with repetitive microtrauma, throwers, cricket players, baseball players, they can get injuries of the attachment of the biceps. And that is what a slap tear is. Usually, these patients have got a good clinical history, and the surgeons would write ? Slap tear. And if that patient comes, please do an MR arthrogram. You would have a better sensitivity and specificity. If you got good quality 3T MRs, you can get reasonably good studies, and we are getting better at that. But if you're starting off, I would suggest that try and develop your eye and your concept by assessing the arthrogram images. They are so much easier. There are a million types of slap tears described, but we tend to limit ourselves to the classical description by Schneider, which he made in 1990 when MR was just about coming into clinical practice. And I'll concentrate on those and briefly touch upon the others. So the type 1 slap tear is that when you get a frayed undersurface of the bicipitolabral complex. So on a schematic, that's what it should look like. In the real life, we know that this is not necessarily abnormal. I just told you that this bit of irregularity can be a normal finding, so I won't call it. Leave that, don't call it. Just mention that it's a bit irregular, but I would say that this is a part of a normal appearance. A type 2, which is an important one, you would get to see a filling in of contrast medium or a bright signal intensity which goes laterally within the tendon. Instead of going medially towards the glenoid, it goes laterally within the tendon. That's a type 2 injury. And that's the important one because you've got a little tear of the undersurface of the biceps. And that tear is indicated by the presence of this bright signal which is going that way. Okay? You can further describe and divide the type 2 injury into the 2A, which is present to the front, a 2B, which is present postero-superior, or 2C, which is both anterior and posterior. So that's a 2C because it's going all the way back. So 2A is to the front, 2B is at the back, and 2C is going all the way through and through. A type 3 is a bucket handle tear. So bucket handle tears we studied in MR of the knee yesterday. They have got a loose fragment and a deep-seated tear, which makes a little rim-like structure, and that's a bucket handle tear. And a type 4 is when you get a bucket handle tear and a tear going into the biceps tendon. So it's a more complex problem. We got a tear, bucket handle, and then the biceps itself, right at its root, is getting torn. So those are the 4 main types of slap tears. Remember, type 1 is almost normal. Type 2 is the tear going into the biceps. 3 is a bucket handle, and 4 is a bucket handle with a larger tear going into the biceps. 5 to 10 are basic combinations of slap tear with the different types of Bankart lesions and the middle glenohumeral ligament tears and the universal tears. So don't worry about those. Try and assess all the structures that I've described to you and put them in separately. So don't worry that if you did not get a type 7 slap mislabeled. Doesn't matter. As long as you've told them that there is a tear of the biceps attachment and there is a reverse Bankart lesion, that's good enough for the surgeon. I'm sure they also don't know that this combination has been labeled as a slap 7, so don't worry about that. We'll miss that because we've already covered that bit. One important lesion is the presence of a paralabral cyst. Remember yesterday I explained to you the concept of a parameniscal cyst, which happens in a horizontal tear. And remember, horizontal tears are the ones which you get to see in older age group, people who like to lie horizontally. And with the passage of time, with the mechanical compression, the meniscal tissue gets extruded and forms a little meniscal tear, parameniscal cyst. We were not too impressed about a parameniscal cyst because all it means is that there is a meniscal tear, full stop. In the shoulder, it's the same mechanism. Remember, it is still the same fibrocartilage. But once you get a large ganglion cyst here, that ganglion cyst is present right next to the suprascapular nerve, which is passing through the spinoglenoid notch. So that nerve can get pressed upon, which can then result in edema of the muscles it supplies, the infraspinatus. See that? Sagittal image, that's the front, that's the back. Big spinoglenoid notch cyst, edema of the infraspinatus. That's the sort of exam case which can come your way. So a fail-pass candidate will pick up this. A good candidate will know that this means that there is a labral tear present. So you will look for that. And the excellent candidate will point out that, look, the nerve is not happy and we've got denervation edema of the infraspinatus. Game, set, and match. So try and get to that stage. You can get paralabral cysts almost anywhere. Remember, these are ganglion cysts. Ganglion cyst means that it's myxomatous degeneration of connective tissue. The inferior cysts very rarely can cause problems of the axillary nerve. Usually not, because they're not large enough and the nerve is a little bit away from the joint recess. It gets more commonly injured in the traumatic setting, which I explained earlier. Okay, so what's this concept of internal impingement? This is an abnormal contact between the articular side of the rotator cuff and the bony glenoid. Okay, so it happens in patients with normal physiological movement, but becomes a problem in repetitive overuse. So again, our favorite athletes, ball throwers, javelin throwers, discus throwers, because they keep on moving their shoulder back and pointing forwards, chucking it forwards with extreme force. And it's constant rubbing of the humeral head against the undersurface of the rotator cuff, which results in a problem. So you've got the classical posterior-superior internal impingement category. These are the patients who get overhead athletes using arm in the abduction external rotation positions. So they may also have slap tears and rotator cuff tendinosis. Clinically, they've got pain in the throwing movements. So the surgeon will ask you if they've got a slap lesion or not. And when you see the MR, what do you get to see? You can see articular side partial thickness rotator cuff tears of supraspinatus infraspinatus junctions. So here, right signal, coronal image, see that? You can get to see posterior superior labral tears, slap tears which are going further back. We can't see it here, but it will be a posterior slap tear around there. And then you get to see subcortical impaction with cysts present at the posterolateral aspect of the humeral head. Remember, that is a normal finding also, I told you earlier. But once you get this bit with the other findings of the slap lesions and the rotator cuff tears, then you can make a diagnosis of internal impingement. And the reverse of that would be the anterosuperior internal impingement. This happens with arm in a position of horizontal adduction and internal rotation, would result in impingement of the articular sides of the subscapularis and supraspinatus. You can get to see injuries of the biceps tendon and the biceps pulley and of the anterosuperior labrum. So here are the examples. You see more problems present to the front with lots of fluid present here, labral problems, significant degree of edema in the rotator interval. So you could ask me that why can this not be adhesive capsulitis? Because these are exactly the signs I showed you with adhesive capsulitis, right? Why? Because it's a different history. It's not a 45-year-old woman presenting with limited movement of the shoulder with a history of around, 6 months or so. This is a 22-year-old javelin thrower who has been trying to compete at international level and now has got a pain at a particular movement of the shoulder. So the history is really, really important. Just based on imaging, you cannot be right. So I've told you how the superior labrum is normally different in different patients, and it's a site of an injury, which is called the slap tear. Best appreciated with good quality 3T MR arthrography. 1.5 MR arthrography is also good, provided you do it correctly. The correct amount of liquid is injected, there are no artifacts, the patient keeps still, and when you want to, you can do ABER imaging. The internal impingement is a rare cause of shoulder pain. I've shown you the posterior-superior internal impingement and the anterosuperior internal impingement, and you need a good history to make that diagnosis. I'm going to stop here and hand over back to Sami Khan. Sir, if you can please show the feedback slide again, because I don't have that.
Yeah, what I'm, Sajid, I think a better way to go, okay, that's fine, it's fine. But what I'm going to do is that we'll say goodbye to you. Thank you very much. It was a real master class. I'm sure people now realize what is subspecialty level in MSK. So it was a pleasure listening to the details of everything. Very comprehensive.